the colleagues that I have, very inspiring colleagues at AEHA. So we are here to talk about carotid ultrasound. We've heard a lot about coronary calcium and imaging and radiation and CT angiography. And this is obviously a new era of PCI, and my PCI is preventive cardiovascular imaging, which I believe is as important as percutaneous coronary intervention, if not more. I have a disclosure to make. I personally perform carotid IMT and plaque assessment for cardiovascular risk assessment in my patients, and I really mean it. And this is often free of charge because carotid IMT is not yet reimbursable in the state of California. It is in the state of Texas, and hopefully with the new guidelines, things are going to slowly change. As Matt Budoff mentioned earlier, coronary calcium has gotten a class 2A indication, and similar to coronary calcium in the new ACC AHA 2010 guidelines, carotid IMT has also received a class 2A indication, class 2A meaning a reasonable test where benefits are greater than the risk. And this is in patients who are asymptomatic and at intermediate risk of coronary disease, and the level of evidence is considered B, even though there is tons of studies, but you will understand why it was given a level of evidence B based on the data that we're just going to discuss. I know this is being a little bit simplistic. We have a very sophisticated crowd here, but I thought if I want to do justice to the study that I'm going to discuss here, I really need to explain how IMT is done and what could be the potential pitfalls in the methodology and the analysis. So here is a pictorial drawing of a transducer insinuating a carotid artery, which is comprised of a common carotid segment above and then the internal and external carotid arteries. Atherosclerosis tends to form where turbulence occurs, which occurs generally at the bulb and the proximal region of internal carotid. Generally speaking, common carotid artery is not as susceptible to plaque formation and atherosclerosis as the more distal segments. We can measure the thickness of the vessel wall, which is comprised of intima and media, as a combined measure called intima media. And the reason we do that is that we are not that sophisticated enough in our resolution of ultrasound to just measure intima, although I think that will also happen. Unfortunately, however, intima media is comprised largely of media, and media may not play as much of a role in atherosclerosis, except hypertension, as does intima, and so you can right away understand why there might be some conflict in the results of the studies which have purely used intima media and particularly only of the common carotid artery which does not form atherosclerosis. Here are two examples of patients, one with normal IMT. You can see both the near wall and the far wall are the terms used to describe the different areas, have got very thin wall, which you can hardly see, as opposed to this patient who has got a diffusely thickened wall, both of the near wall and far wall of the common carotid artery as well as the bulb. Plaque, as you know, is really the process that we are after to detect by imaging, and it tends to be an intimal process. So if you're really truly looking for atherosclerosis, you need to be looking for plaques and measuring plaques. Not only do we have an issue with the different types of segments that you image, but the imaging studies that have been used so far from the early 80s in IMT have varied in whether or not they use, as I said, common carotid alone or inclusive of bulb and internal carotid. They image it in a one single shot, which is a two-dimensional imaging, does not do justice to the entirety of the carotid system, versus using multiple angles, whether they image only the far wall or combine it with the near wall, and most importantly, whether or not plaque was assessed in the measurement of IMT or as a separate entity. We've also got variation in the phase of the cardiac cycle, the end diastole or end systole during which IMT is measured, and that alone can have an effect on IMT, and whether or not one uses single or multiple frames. And then we have a problem with the way the IMT result is expressed. It's not like an Agatston score and you get a number from 1 to 400 or 1000 like you do for coronary calcium. You can express it as an average mean or an average of maximum or only the maximum, and you can measure IMT either by the calipers on the ultrasound system or be more sophisticated and measure use some automated edge detection tool, which obviously will increase your accuracy and comprehensiveness. We also vary in our definition of what is an abnormal IMT. Again, unlike the cutoffs that we now beautifully have for calcium of 0, 100, 400 and more, we still are struggling with what is abnormal IMT, and the consensus has emerged over the last few years, whereby it appears that 75th centile of IMT or greater for age, race, and gender is probably going to be the definition we're going to use, at least for the time being. Although studies have used standard deviation, upper and lower quartiles, some studies have even used an absolute number for IMT being abnormal, being more than 0.9 millimeter. You can see the measurement is sub-millimeter, which is why it is fraught to methodological variability if you don't do it carefully. Both the ACC, AHA, and ASC have adapted the 75th centile as the way, as well as our SHAPE task force is using the 75th centile. And then don't forget, there's also a difference in resolution of the ultrasound systems. The most recent ultrasound systems can measure as much as 0.1 to 0.2 millimeter pixels, whereas some of the earlier generations were able to separate out only pixels which were 0.3 millimeter apart. And then obviously the frequency of the transducer you're using also makes a difference. What about plaque? Are we more clear about the definition of plaque? Well, there are two definitions floating around. One is a focal thickening of the carotid wall that's at least 0.5 millimeter in thickness, or is 50% of the surrounding IMT value. So any little bump, in other words, would be a plaque. The European Mannheim consensus defined a plaque as a CIMT thickening of 1.5 millimeter that is distinct from the adjacent boundary and protrudes into the lumen. So these are the two definitions of plaque that are floating around, and this is by 2D. Then the studies have varied in how they quantify plaque. We can just say plaque present, plaque absent. That's one way. It's very simplistic. Or we can try and be more quantitative in assessing and measuring plaque burden. And the studies that I'm going to discuss have used the number of plaques, plaque thickness, plaque area, plaque volume, and vessel volume. And these are more and more better ways of assessing more three-dimensionally the plaque volume, which is the new era we are now entering into, which is really where we need to go. And then there is qualitative assessment of plaque, as Dr. Narula alluded to in his talk, by ultrasound that would relate to plaque heterogeneity, plaque irregularity, plaque vascularity. Fine C from Chicago is a big proponent of this, and plaque calcification, which really express different phenotypes of atherosclerosis within a plaque. Here are some examples of the problem and the variation in plaque morphology, and you can see from these examples, this is a focal plaque of the far wall of the bulb with calcification and acoustic shadowing. But look at the IMT, it's pristine, it's nice, it's thin. As opposed to this patient who has irregularity and thickness of the IMT, and there is plaque, and there is calcium. This patient has a focal long plaque, which is smooth. This patient has multiple plaques in the bulb, and this patient has calcified plaque, which is largely layered along the vessel wall. So if you just said plaque yes and no, you can imagine how you could misclassify some of these individuals who you could perhaps classify by better methods. So having discussed some of the pitfalls and some of the ways the literature exists in the area of IMT and plaque, I would now like to, with you having this background information, now come up with some more recent data that I believe will actually help us guide in a direction which has been very, very confusing and perplexing in the past few years. So this is a meta-analysis. It just was published in Atherosclerosis in 2012, where they took 11 studies and 54,000 subjects or so to see whether or not there is a difference in predictive power of IMT alone versus plaque in predicting cardiovascular risk. And this is the risk of future myocardial infarction in these asymptomatic individuals. You can see that the diagnostic accuracy of plaque assessment is better than IMT assessment alone, with a ROC of 0.64 versus 0.61. And the diagnostic odds ratio, when adjusting for all the framing and risk factors that we know of, was 1.35. That means 35% better than carotid IMT, and the sensitivity of predicting future events, as you can see, is higher with plaque. So it appears that plaque seems to be better, and studies that have not measured plaque may therefore not give you the right answer. Here is another study, a meta-analysis of many IMT studies which are listed here. This was published in Circulation in 2007, and you can see that overall, after adjusting for age, gender, and other vascular risk factors, for each 0.1 millimeter increase in IMT, there is a 10% risk of increase in myocardial infarction, and a 13% increased risk of stroke across the totality of these studies, which are all variable in how they measured IMT. And when you look at a standard deviation and not the 0.1 millimeter increment, there is a 26 and 32% increased risk of myocardial infarction and stroke with IMT. So IMT has value, but these studies are combined studies, which probably some of them included plaque in their measurements. Now, as opposed to that data that I just shared with you, if you look at this study, which is again looking at all the studies that at least measured the common carotid artery IMT. They just looked at those studies and they just looked at the data from common carotid IMT. They ignored the bulb, they ignored the ICA, they ignored the plaques. When you look at this kind of meta-analysis, it appears that CIMT does not add anything to risk prediction when added over and above Framingham risk score. So 0.8% of people were reclassified. In intermediate risk also, the classification was very poor, 3.6%. So to me, it tells me that there is a story that's emerging, that perhaps it's not the IMT we should be going after, it's the plaque we should be going after, because essentially that's what's atherosclerosis, and that's what leads to coronary events. And this data supports the point that I'm trying to make, which is a reanalysis of ERIC data, the atherosclerosis risk in community studies, which was published in the late 1980s based on IMT data alone. And now Naqvi's group, they separated out how much more incremental risk can you get if you also just looked at plaque. Now, ERIC's study was conducted in the 80s. There was problem with the pixel resolution in older systems. The way they classified plaque was yes and no. 57% of internal carotid IMT could not even be measured. So you can imagine we have problems. And yet, if you add the plaque data at any level of IMT, 25th centile, 25th to 75th centile, or more than 75th centile in both men and women, there is an added improvement of risk prediction if you also included plaque in your assessment. And when you compare the total risk factors versus and include IMT in it and plaque, then you're able to reclassify about 10% of individuals. The NRI is 9.9% for all the risk, for all categories of Framingham risk, and about 22% for intermediate risk, which is really where the group that we are after. The categorization was better in women than it was in men. This is again some more data to support, to evaluate the differences between plaque and IMT. Again, a recent study from 2011, which is looking at about 6,000 individuals. This is a little different from Eric's study, which was confined to 45 to 65 years of age. This is looking at 65 to 85 years of age. There's mean follow-up of about 5 years. And again, just by categorical presence of plaque, a little bit more sophisticated, we are saying either no plaque, plaque at one site, or plaque at two sites or more. The hazard ratio for first coronary event for one plaque was 1.5, and for two or more plaques was 2.2. So about just over twofold increased risk as compared to those who had no plaque. There was an improvement in ROC curve by adding highest number of plaques versus no plaque, and you were able to reclassify more individuals by using this methodology, versus in the same studies, when you looked at the different quartiles of IMT alone, you were not able to separate out the risk categories between the lowest and the highest IMT. The hazard ratio was 0.8. This is the data from Turumzo's study, which was conducted in patients between 25 to 85 years of age, 84 years of age, about 6,000 individuals, followed for about 6 years. These are free of cardiovascular disease at enrollment to look at first myocardial infarction. And again here, now we are kind of being a little bit more careful in how we separate out the plaque burden. In men without plaque versus the highest tertile of plaque, the hazard ratio for myocardial infarction was 56% higher compared to women, where it was 395% higher. So women, if you detect plaque in a woman, it appears to be far more predictive, at least from this study, than in men. Whereas if you looked at IMT, both in men and women across quartiles, yes, there is some separation, but if you excluded the bulb IMT, which to me means plaque and atherosclerosis, you lost this predictive power of IMT in this study. The same study data set was extended to a 10-year follow-up published recently, this time looking at the stroke risk, and very similar to what we saw with the myocardial infarction risk. from no plaque to the highest quartile. After adjusting for all the other risk factors, the hazard ratio in men is 73% higher versus 62% higher in women for plaque, whereas no significant separation was observed when you looked at across the quartiles of IMT in this study. So the data and the way you infer and interpret the data really appears to be telling the same story. This is the recent study that was mentioned by Dr. Falk in his very smart analysis of data from the various studies. This is Polak study from New England Journal. About 3,000 individuals. These are Framingham offspring study who were followed for about 7 years. They looked at CCA IMT versus ICA IMT, and to me, as we discussed before, ICA is where plaque tends to form more. ICA is where media is thinner than intima, and so we have more representation of atherosclerosis. The hazard ratio for one standard increase in CCA IMT was 1.13, and for ICA IMT was higher, was 1.21. And if you look at the data a little bit different and use the Mannheim classification of plaque of 1.5 millimeter across all categories of Framingham risk, presence of plaque, which means IMT of 1.5 millimeter or more, was able to separate out patients in all the different categories into lower versus higher risk. This is the data from North Manhattan study, which has also been discussed here. I'm just trying to share with you studies that have tried to address this issue that we have of not being able to classify or quantify plaque burden. Here, they're looking at no plaque versus a mean carotid plaque thickness, which is simply how much it protrudes into the lumen. And just by using that very simple measure, you can see that those patients who had a plaque thickness of more than 1.9 millimeter, about 400 individuals, have a higher probability of event at follow-up compared to those who had no plaque. Interestingly enough, 44% of Framingham low-risk individuals became 20% risk if you actually use this definition of carotid plaque thickness of more than 1.9 millimeter. Now, as opposed to the absolute measurement of IMT, how are we doing in terms of progression of IMT? We've talked about progression of coronary calcium. As you can see, IMT measurement is less than 1 millimeter in general. And to be accurate with progression, which is now we have to cope with changes of like 0.1 or 0.05 millimeter or even less than that, anywhere from 0.01 millimeter to above, we actually lose that definition. We don't have the resolution to be able to measure progression from year to year accurately with ultrasound. So in this meta-analysis of multiple studies, which had at least 2 ultrasound tests performed, while the IMT at both the intervals predicted cardiovascular events with a hazard ratio of as high as 2, there was really no predictive value of changes in IMT in these 16 study meta-analysis over time. So progression is an area where we are weak. What about plaque characteristics? This is the total plaque risk score used by Dr. Taboul from France, who instead of just saying plaque yes and no, they actually looked at stenosis degree, plaque surface irregularity, echolucency, and texture, and allocated a score of 1 to 4 to all of these categories, and found that yes, presence of plaque is better than IMT, but presence of this high-risk plaque is even more predictive than simply saying yes and no to the plaque. Now we are really, if you want to quantify plaque burden, you really need to be three-dimensional. And we have understood that simply by adding 1 plaque, 2 plaque, 3 plaques, plaque thickness, we are able to improve our risk prediction. Won't it be good if we were able to quantify the entirety of plaque in a carotid system? And really the best way to do that would be three-dimensional ultrasound, which we've had a limitation with so far. But this is the data from a bioimage study which was published in JACC Imaging. For the first time, Dr. Spence sitting here has used three-dimensional echo plaque volume before that I'm going to show you. But this is a new technique in Philips ultrasound system where you image the carotid artery from the base of the neck all the way up, slice it into multiple segments, measure plaque in each of those slices, and then put it together as a combined plaque burden. And for the first time, we are now seeing that we have a technique that probably correlates with coronary calcium burden with a very high chi-square value of carotid plaque size by three-dimensional imaging. Notice in the same study, even though there is a correlation between coronary calcium and IMT, the relationship is much weaker. This is the study that PK was alluding to. This is a smaller study, obviously, just over 100 patients. But look, even in patients who have a coronary calcium scan of 0, we have about over 40% of patients who we identified at least one plaque in our study. But what I want to point out in this slide is that there appears to be a relationship between plaque and coronary calcification. As the coronary calcium score increases, this is from Dr. Berman's lab, plaque score as we measured by IMT in our lab at Cedars increased. These are the percent plaques. When your coronary calcium score is more than 100, or almost 80% of your patients have plaque. A nice relationship, whereas we did not find this kind of relationship when we looked at IMT. Again, pointing to the fact that it is the plaque that correlates with calcification, which is really calcification in the plaque. Now here is the data that I was referring to. This is the MESA study showing that at any level of coronary calcium score, even in coronary calcium score of 0, which as mentioned occurs in about 50% of the population, you could use carotid. This is simply IMT. This is not even plaque assessment. This is MESA study, which did not use plaque assessment. Even if you just use IMT, you're able to risk stratify. If you were using plaque and you were concerned about an individual's strong family history, calcium score is 0, they're relatively young, they may not have had time to develop calcium. You have other modalities, a non-invasive method of assessing plaque by carotid ultrasound. And this stratification actually held true at all levels of coronary calcium by IMT in this MESA study. This is the data from Dr. Spence. He may be sharing the same slide with you, but he has been more forthcoming and visionary as far as I'm concerned in determining that really the money is the plaque and not the IMT. So they have actually been using total plaque area assessment by using this methodology where any IMT which is more than 1 millimeter is included in plaque assessment. And they have found that in about 1,500 or 1,600 individuals, as your plaque area increases, your event-free probability decreases over time, so that those with minimum plaque have a 5.6% 5-year risk, and maximum plaque have 20% 5-year risk. That's 20% 5-year, that means 40% in 10 years. That's really high risk. And in the individuals in whom they had 2 scans available with progression and regression data, you can see that those who progressed had higher risk than those who had no change or regressed. In other words, unlike IMT, where we have a problem with measuring progression and regression, it appears that we have a tool in plaque assessment where we can measure progression and regression, and these 2 studies highlight that point. Again, this is data from Dr. Spence's group using 3-dimensional measurement of plaque volume. This is only 38 patients. This is not thousands of individuals who are randomized to placebo versus atorvastatin. Obviously, you could do that earlier on, but no more. And you can see that placebo group had plaque progression or no change, and there was a regression of about 100 millimeter square plaque volume in those who were randomized to atorvastatin, which is actually a relatively easy change to measure as compared to trying to go after a 0.01 millimeter change in IMT in an individual over time.
In 3 months.
In 3 months. Okay, thank you for pointing that out. This is another study now looking at vessel volume in addition to plaque volume. The vessel volume has some role to play as well that we have ignored. Remember, there is this negative, this remodeling that occurs, the positive remodeling of the vessel. I think there is something in there that we should be looking at too. And this was borne out by this very simple study. I think this is also a relatively small study, about 150 patients who were randomized to 3 different types of diets. And while there was no difference in the changes in vessel volume across the 3 types of diets, but there was a very nice correlation that was shown. More aggressive your systolic blood pressure lowering, more aggressive the reduction in vessel volume. So we seem to be getting tools available to us which will help us evaluate not only the absolute burden of atherosclerosis, but the effect of therapy or lack thereof in progression and regression. So in summary, we have, yes, we've had lack of uniform definition of IMT and as well as of plaque. If we use CCA, IMT alone without including the bulb and the IMT or plaque, you do not, probably will be using a very useful clinical marker over and above framing a risk score to predict cardiovascular risk. Plaque assessment improves cardiovascular risk assessment better. And if you were to quantify plaque with increasing sophistication, you are able to predict cardiovascular risk even better, and you also have a tool in plaque where you can actually relatively easily in an individual measure the effect of therapy and progression and regression.